there are 5 total objectives in the citywide business plan, and each of them have 3 to 5 strategies under them. So we won't, the first few slides here kind of go through those. We won't spend a lot of time talking through what they are since we're going to go into detail with all of them. We have high-level measures of success detailed at the beginning, and the data here actually reflects what was shown in December's meeting, because we are still, well, actually, as of today, we're in FY19, but when this presentation was put together, we were still in FY18, so we don't have year-end numbers there yet, but we will be updating those. And as always today, we will be live tweeting from @KCMO with the hashtag KCStat. So if you have questions or interested in topics, you can certainly feel free to respond there. So with that, I think we will go into the first objective, which is to reduce crime among all age groups, placing an emphasis on young offenders. And before we actually get into the first strategy here, which deals with kind of cross-cutting efforts to deal with anti-violence initiatives, we do have some general crime statistics, which I'm going to go ahead and walk through since KCPD was unable to attend. So the first one is crimes against persons on an annual basis. So this is all types of crimes against persons rolled up together. It shows that over the last several fiscal years, we did have an increase in year-over-year crimes against persons for, good morning, for FY18, we only have year-to-date numbers through February, so we're missing a couple of months there, so we can't say definitively what the trend is for FY18, but if we project out the proportion of crimes that usually occur in the months of March and April, it does look like we're trending toward a slight decrease in crimes against persons this year. In terms of the most sort of prominent statistic in crimes against persons, the homicide summary, again, looking at year-over-year trends, the daily homicide brief actually tells us how many homicides had occurred as of a certain point in time. So this is as of April 27th each year, and so you can see we are above that point for the year to date. As of April 27th each year, we're higher than we've been, and have obviously had an increase year over year the last several years. Crimes against property, similarly, in contrast to crimes against persons, was on a decline. Last year saw an uptick, but similar to crimes against persons, the year-over-year projection is looking like a slight decrease of about 2% for the current fiscal year. The next couple slides just show a snapshot of the trend for resident satisfaction with crime prevention. Has also seen a decline the last couple years, and currently through the third quarter is trending toward at 33% satisfied. We should have our fourth quarter numbers, which will give us the annual number very soon. Similarly, satisfaction with visibility in police and neighborhoods is trending down currently. Feelings of safety in the city, which is the blue line, and how safe you feel in your neighborhood. How safe you feel in your neighborhood generally is higher than how feelings of safety in the city, but both are trending down for the current fiscal year. In particular, feeling of safety in the city is trending down by about 7% year to date. And finally, looking at those feelings of safety both in the city and in your neighborhood, broken out by council district, you can see that there are some pretty substantial geographic differences, particularly in feelings of safety in your neighborhood. Where you see the low end of satisfaction, Council District 3, 38% satisfied, and on the high end, Council District 2, 76% satisfied. So behind those citywide numbers, there are some differences based on geography that are at play. So if there's no questions on the crime and resident satisfaction, we'll move into the specific strategies to deal with to deal with the issue of crime prevention specifically. So the first strategy is to expand the city's efforts on building relationships with partner agencies and to increase youth intervention and anti-violence programs. And so under this, we're going to first hear from the health department.
Good morning. Tracy McClendon Cole with Deputy Director of the Kansas City, Missouri Health Department. One of the things that I'd really like to highlight about Kansas City is that we are a city of resiliency. And one of the things that we have as a hallmark is the ability to leverage resources and partnerships. But one of the things that we haven't done as successfully, especially in the realm of violence prevention, is pull those collaborations together. But that is something that is beginning to change. And that hallmark is starting with the Violence Free KC Committee that is under the Kansas City, Missouri Health Commission. We are trying to begin the process of actually communicating across systems, because one of the things that we haven't done in Kansas City is look at violent crime, specifically looking at resiliency factors. What are those things that can make a resilient community, a healthy community, increase life expectancy, thereby increasing the opportunity for life expectancy, hope, and resiliency? Those are the hallmarks if we want to see a reduction in violence, if we want to see a reduction in homicide. We have to have a resilient community. And that's something that uniquely is something fashioned through the health framework and looking at it specifically, looking at violence prevention efforts. One of the things that we also like to highlight is that the public health framework is not mutually exclusive of the criminal justice framework. In fact, it's very complementary to it because it does not replace criminal justice, because the good work of law enforcement, good work of judges, good work of municipal court is definitely needed. But at the same time, we have to build in those community supports that increase resiliency across sectors. Those things that are spoken about in our citywide business plan. So when you see strategy A and the wording that is currently there, one of the things from a public health perspective, we're hoping that we can evolve. We're not just looking at expanding partnerships with youth intervention or anti-violence programs, but we're talking about violence prevention programming, because wording matters. The types of words that we use are extremely important to the framing of how we begin to build in Kansas City. One of the things that we know is that there are many forms of violence and trauma in our city. It's not just community level violence that we're dealing with, but we have to be able to address structural violence, sexual violence, child abuse, intimate partner violence. And we also have to begin to change and transfer our thinking beyond just moralistic, bad people, bad choices, to truly looking at science-based processes, science-based results, and science-based frameworks. Because we know that key to Kansas City's in increasing the high levels of trauma from a high level to a lower level is really breaking down those social networks. Next slide, sorry. Those resilience factors that you see, people, place, equitable opportunity, they also appear in our citywide business plan. These are not mutually exclusive. These elements are extremely important when we're talking about how do we build not only the health sector, not only the criminal justice sector, what is the responsibility of education? What is the responsibility of the arts? What is the responsibility of entertainment? What is the responsibility of media? What is the responsibility of business, and so forth? All of these sectors have a role in a systems approach, because it's not just one unique individual agency or program that's going to solve the issues that we have in our community. We have to have a collective framework. That collective framework also has to be bounded by an evaluation and indicators that actually prove that we can move toward resiliency. We can do this, Kansas City. I know that we can increase opportunities for people. I know that we can increase equitable opportunity as well as provide opportunities for place. But it's going to take a collective framework. So instead of it just being a public safety report out, it really needs to be a public health and safety, looking at how are we looking at it from a community perspective. Just recently, the Violence Free KC began to embark all of the agencies that are working a part of that framework at looking at what is their role and responsibility and what are their key performance indicators in terms of dealing with increasing that resiliency for people, place, and opportunity. we began the process of working with one of our evaluators to truly understand what are the process elements, what are the programmatic elements, what are the personnel staffing needs that we need to do, as well as should we evaluate ourselves? How are we going to determine success if we're looking at it from a systems approach, not just health, not just criminal justice, but all the sectors together, working in a collective framework? Because ultimately, we want to be able to address outcome indicators. Those baseline data that you may not be able to see are really focusing on understanding how do we address trauma and ACEs, adverse community experiences, as well as adverse childhood experiences. It's extremely important that we understand these concepts and begin to address them at the lowest level possible if we're going to address resiliency, if we're going to address place, and if we're going to address economic opportunity. We know that we can reverse this tide, but it's going to take a comprehensive approach, not just a one program or two program or three program approach, because we've done that. But cities who have been successful have a collective framework. That collective framework is currently being commissioned in partnership with the Prevention Institute, with our Youth and Family Violence Prevention Plan. But prior to lifting that, there are significant alignments that we have to do within the system to be able to get to those outcome indicators for success.
And as Tracy was talking about building resiliency, one of the initiatives through Aim for Peace is our Kansas City Violence and Trauma Response Network, in which we provide wraparound services for male survivors of violence between the ages of 13 to 24 years of age. With this effort is a pilot program in which we're just focused in on sectors 331 and 332 in Kansas City. We address violence, we address the trauma and the resiliency of our youth. Some of the efforts that we have coming up is providing more trauma-informed workshops as well as mental health first aid trainings for our community. We're also going to have some summer events that we're having that revolve around hope and healing in our community. And some of the other aspects that we have is that that Aim for Peace is actually expanding our hospital prevention program into another hospital in Kansas City, which is in Council District 5. This right here is just some of the accomplishments that we've had. In 2017, we responded to 253 violent incidents. That's from our street team as well as from our hospital, as well as in 2017, we provided 7 community trainings around mental health, crisis intervention, as well as trauma-informed care. And we identified 96 survivors of violence in which we provided 59 referrals of service. But this year to date, we're really focusing in on our youth and really providing them with those wraparound services in which you can see that those numbers of referrals for service have already doubled year to date. So we're just really focusing in on them and providing them with the necessary services that they need in order to be resilient in our community.
Hi, good morning. My name is Erica Taylor, and I'm representing the Health Department's Aim for Peace Trauma Network. And what we have the opportunity to do here starting in June is to launch a case review. Now, a lot of times when we hear about case reviews, they are about fatalities, children in Missouri who have unfortunately expired due to some sort of violent or traumatic experience. What we have the opportunity to do here in Kansas City is to look at youth who have been hurt, but they still have an opportunity to be resilient because they are still alive and breathing and with us. We have the opportunity to look at the circumstances that are around this youth. How are you feeling today? We have community health workers that talk to youth. What's your mindset right now? We're looking at family systems. How's your family doing? We're looking at structures that are in the community that might cause harm or opportunities to provide more protective factors in the community, and then going all the way up to policy level issues or challenges that we can begin looking at to really start to address those ACEs in the community and through that child. These case reviews will occur quarterly, again, starting in June. The purpose is to look at youth, young males, survivors of violence, ages 13 to 24, who have suffered from trauma or a violent injury, and defining realistic solutions across multiple levels, across the individual level, relationship level, community level, to really start to impact change in utilizing that multi-sector collaborative approach that the health department is adopting and utilizing. Thank you.
Is that it for that segment? Oh, go ahead, I guess.
Good morning. My name is Nefertari. I'm the Community Engagement Manager with Aim for Peace. The Youth Ambassadors of Peace was created out of the Kansas City Violence and Trauma Network, Response Network. These youth are mostly male survivors of violence and trauma, ranging in ages 13 to 21. We currently have 8 males and 1 female who are dedicated to building a path of resiliency in their lives with our help. Our direct work with the youth started in February 2018. We were given the opportunity to introduce our youth to the 3rd District meeting in February 2018. In March, it was all about who are we and what is our role in the community. Youth Coordinator Berdina Oliver worked closely with the youth to answer those questions. The youth went on a week-long spring break tour during Kansas City Public School spring break, which was March 26th through the 30th. The youth were exposed to financial literacy at the Federal Reserve Bank, where they were tasked with creating a budget. An educational resource at the W.E.B. Du Bois Learning Center for tutoring after school. The youth were able to take a full tour of the center and take the math assessment, and the adults took the test too, and needless to say, the youth beat us at the test, so. Also, they gained knowledge in the radio engineering at the Black-owned community resource KUAW Broadcast and Media Production Company located inside the W.E.B. Du Bois Learning Center. We took the opportunity to engage with the youth with social service providers and literacy information at the KCPS Community Literacy and Resource Fair. The Truman Medical mobile food truck was there. Our youth were given groceries with fresh fruits and vegetables. In that same day, we also took our youth to FEC for employment and training opportunities, also ATA for discounted rates for youth to ride the Metro bus. Preventive health and education was the focus as the youth were taken on a tour to the KCHD, Kansas City, Missouri Health Department, and they also had a tour of that building. A Q&A session was conducted afterwards to ensure the knowledge of all the services provided at Kansas City, Missouri Health Department. And lastly, we took the youth to Municipal Court for a tour of the building, the beautiful new building, and I'd like to really let you all know that that building is absolutely beautiful now. Thank you. And they also had the opportunity to sit down with the Honorable Judge Carter, Bland, and Peterson, who spoke about their career paths to judgeship. The youth were able to ask questions about the law and policies. The month of May was focused on peer messaging, and also the young people were instructed on how to construct letters and writing poems to honor the woman in her life in preparation for Mother's Day dinner, which will be held May 9th at the Brush Creek Community Center. The poems will be typed and framed and also used as decoration, also given to the women at the end of the evening. The peer messaging will be pushed out via social media by May. Did you all know that May is Mental Health Awareness Month? We have joined forces with SWOPE Health Services, Cornerstones of Care, Rediscover, Parks and Rec, to put on a mental health awareness block party on this Saturday, May 5th, from 9 to 2 p.m., and it will be at the SWOPE Health Services parking lot. There will be a family walk starting at the Spirit of Freedom Fountain, and the event starting at 10 o'clock. Our youth have named our tent the Heart of Peace. In the tent, we will attract youth ages 13 to 24. We will provide haircuts, along with a workshop led by the youth. The youth will help other youth develop a self-care plan for when they have been triggered by anger. They will also help other youth with projects of peace where they can draw what does peace look like to them in their minds. We are looking forward to exposing our youth with more community, neighborhood, and social activities event this summer. Working with our partner, Bonnie's Free KC, and other community partners. And for service projects, we will be executing this summer, adhering to the iRise brand ambassadors program. Thank you.
That it? Good. Couple of questions. When you say that you've, well, first, I appreciate the coordination discussion. Are you coordinating with Kamisha Stanton?
Yes, she's actually a part of the Violence Free KC. She comes every single month and gives an update, as well as we have a coordination between Gina English, Kamisha, Cynthia Carlson, and myself, who also meet on a monthly basis to just coordinate and divide where we're going to move in terms of collaboration.
All right, cool. We need to add Kamisha to the Casey staff for public safety.
She's actually, her slides are the next few, and Juan Ramiro is covering them.
Okay.
Good morning.
No, we're not, I'm not done.
Oh, okay, go ahead, go ahead.
Calm down. When you say that you've responded to violent incidents, tell me about what that means. What does that response look like and entail?
It entails a couple of different things. When we respond to incidents of violence in the street level, Aim for Peace responds initially, in which they go around and they try to calm the situation down as far as that immediate response. With this project, the Kansas City Violence and Trauma Response Network, we've added additional layers of responding to incidents of violence, where our second layer, in partnership with the Concerned Clergy Coalition, we go out and canvass the blocks in the areas in which that incident occurred, in which we identify survivors of violence just by having those basic conversations with the community, asking questions, how are you today? Are you good? And then being able to, acknowledge whether or not if they need any services, whether or not if their children need any services. And then we have an additional layer of response in which we have another canvassing effort with communities creating opportunity in order to mobilize that community. On the hospital side, we get calls from Truman Medical Center in regards to any penetrating intentional injuries that come in through the emergency room. Our hospital staff, they respond in which they try to prevent retaliation as well as re-injury for that patient.
Okay. When you say, I assume that you were talking about your efforts with CCO, mobilize the community, what does that mean?
Mobilizing community is basically being able to push our messaging in regards to violence prevention in the community and being able to identify any different policies that may be addressed that are attributing to violence in the community.
In addition to that, because CCO is a great agency in terms of collaboration within the community, any type of initiatives that are coming forward that affect that people policy in place that we talked about, we also are working with them collaboratively on that as well, to engage, increase voter enrollment, be able to make sure that folks understand the importance of voting, the rights of voting, why the history of voting is important, in addition to some of the other policy issues that may come forward.
Okay, there's different types of collaboration. There can be episodic collaboration when there are a specific incident, people come together and collaborate. There can be programmatic collaboration where you're sharing programs. There can be umbrella collaborations where everybody's under the same umbrella. Everybody knows what everybody else is doing, and there is some feedback and give and take there. Describe the collaboration that you have with these agencies, and what is the system to ensure that that collaboration holds?
For the Violence Trauma Network, it's exactly as you described in the latter. It is a collaboration that's built off of a memorandum of understanding.
Okay.
And so there's a contractual relationship that has been established. But beyond that contractual relationship, it's a understanding, a meeting of the minds, if you will. So not only do we meet on a regular basis, but we also do evaluation points. So every single month, we have our evaluator come in and give out where are we at with the particular collaboration, how effective is it meeting the need, is it actually meeting the targets components of the grant and how that goes forward. For the Violence-Free KC collaborations, that's purely by will of the or agencies coming. But one of the things that we found is that it's becoming more organic. And so in terms of having the numbers of people who are on the roll in terms of the organization, it's there by voluntary. And so all of the agencies that are there have begun to either, like beyond the conviction, begin to come to the agency and begin to actually participate in those monthly meetings. And then as they become more and more involved, then we begin to invite them to become a part of a smaller group. And one of our work groups, Cynthia will talk about those a little bit later, but one of the things that we do is try to organically move that. So not everything is just by a contract, but also by commitment. And that commitment level is making sure that as we're moving forward with the systems approach, we're also evaluating what are the indicators that you may have for your agency, but then also what are the indicators as it relates to the system. And so that agreement was had as a group. So we codify those meetings every single month, and those meeting notes stand as like our standing agreement, if you will, amongst the parties.
Good. So how do you know that you're succeeding? What is the point that you can say that you are making, well, progress I think you're probably making every time, but how do you know when you've gotten to a point where you're nearing success?
One of the things that we've done, and we're in the process, so I will say that this is an evolution, because one thing about evaluations, as you may know, they are not static. They're something that evolve over time based on the need as well as looking at process. So when we look at what is success, the name Violence-Free KC is exactly what we're trying to achieve. And so and when we see that name actually become actualized within the community, then we'll know that we've actually reached a measure of success. And that's across all the different levels of violence, not just one form.
Thank you very much.
We're ready? All right, Juan Ramiro Sarmiento,
I'm sorry, I never said yes.
are you ready now?
Okay.
There we go. Juan Ramiro Sarmiento with the mayor's office. I'm here on Kamisha Stanton's behalf. She's a violence program coordinator and currently on maternity leave, so I'm going to do my best to do justice to her report on the Quarter 1 initiative's focus. The first 3 items that she focused on were the Youth Master Plan, the Public Engagement and Mentoring Program, and the Storefront Community Resource Center. As we have heard already, Kamisha is very much at the table with those conversations with the Health Department and the Prevention Institute regarding the Youth Master Plan. I think currently we are at the community input stage. And several folks from the community have been interviewed in regard to inform the plan, as well as collected around 9,000, perhaps more now, community survey responses. And I believe the expectation is for the plan to be presented by the fall of 2018 and formulate the actual content of the plan throughout the summer. The Public Engagement and Mentoring Program, Kamisha mapped 27 programs throughout from the beginning of her term, and rather than create a new mentoring program, they're creating this coalition of mentoring programs throughout the city, and the plan implementation is July 2018, and the purpose is for this to serve as a base of the mentoring programs to continue to track what other ones sprout throughout the city, and then provide training and coordinate resources, as well as communicate and defer youth if they may not necessarily be, if the program cannot serve them or they're not the target population, that they defer them to other programs across the city that can help them. But the purpose is to not let children fall through the cracks and provide the mentoring programs that are available. As you can see, we have 27 of them. It's just that they weren't necessarily talking to each other, and so that's part of her job. The other one, the Store Community Resource Center, that's something that Kamisha has been working with Kansas City Police Department, specifically the social workers within the department, Gina English, and then the Kansas City Public Libraries. The plan currently is for the Blueford branch to be the pilot, and then upon review of the outcomes from that, the intent is to duplicate that model and expand it to the other branches, and they will be providing services specifically targeting the pervasive forms of violence that were already mentioned. And the Blueford Library is supposed to have a community research research specialist and a fellow, along with mental health trainers, behavioral health programming, de-escalation training, and child abuse training as well, to be able to provide assistance on a weekly basis for that community, and then for expand beyond that. So those were the 3 items that the violence program coordinator focused on the first quarter. Upon her return, she'll be focusing on continuing to work on those areas, but also expanding her focus to the electronic database of community resources, which was one of the other recommendations in the public service campaign. For the database, the main stakeholder is Money Smart KC. In her asset mapping, she came across this organization who had already been doing a lot of the electronic database collection of community organizations that were already out there. And so there's some conversations ongoing right now as to what the city would like to see from that, and what kind of changes need to be implemented in order to serve and fulfill the recommendation of the electronic database of community resources. So that would be the part of the next focus. The other one, the public service campaign, Kamisha's working closely with the U.S. Department of Health and Human Services and our health department. And that is touching with the iRise campaign, which is out of the youth master plan, whose main purpose is that narrative change from the current one of pervasive violence to one of hope, and providing those providing a better message for the youth in the city. But that is something that she's been working on with Kamisha Stanton, with Denisha Snell, who is working specifically with the iRise campaign and driving that for the health department as an exterior consultant. But that's, I believe, all I have for that. And if you go on to the next slide, you'll see the 30, 60, and 90-day plan, which I'm sure she will resume upon returning from maternity leave, which I believe is early June. All right, that's all I have.
Thank you, Juan.
Yeah.
Appreciate it.
Okay, so that actually takes us to the end of Objective 1, Strategy A, and on to Strategy B, which is around working with area school districts and other organizations to expand hours of programming for the city's youth. So we actually have, realizing that the slide got a little messed up there at the bottom, the tables. Julie, can you move those up? So we have a couple of updates here from Hire KC Youth and Full Employment Council, representing 2 of the major investments by the city into youth summer programming from the jobs perspective. And so, thank you. So these numbers on the Hire KC Youth Summer Program were provided by KCSIC, who is coordinating Hire KC Youth, or facilitating on behalf of the city and the mayor's office. And I don't think we have anybody here from KCSIC, but if there is, no, yeah, okay. So they were able to provide this report. Basically, at a glance, we have the summer 2017 numbers and the summer 2018 year-to-date, but obviously we're not really even into summer, so those numbers really just reflect the career fair, which has happened, as well as the applications to date through mid-April, which is a fairly early point. So hard to measure the true extent of the program at this point, but just looking at the career fair, huge increase, 200% increase in employers, 50% increase in jobs available. And then there is the existence of the Jobs Board, which I believe is a new tool this year that's seen a number of jobs posted and youth profiles created. So I'm sure we'll come back and report on the outcomes of this at the next KC Stat. The Full Employment Council represents another set of youth programs that focus on workforce development, and there are 12 programs in total that target youths aged 16 to 24. So the table here highlights just 5 of them total. So the ones with the highest level of participation. There's the Summer Job League, Tech Hire Program, WIOA, both the adult and dislocated worker, and the youth program for economically disadvantaged youth, and then health profession opportunity grant. And so obviously many of these are grant funded too through the federal or state government. So you can see the overall participation as well as the job placement rate to date in many of these. And then at the bottom are detailed a few other programs with smaller enrollment levels. Okay, and that takes us to the last strategy in this section, which is about communication specifically, and we're going to turn it back over to health. And I know there's a number of slides here, but just in the interest of time, if we could kind of move through those fairly quickly. I know that there's a lot of detail, but.
Yes. So good morning, Cynthia Carlson with the Health Department. Just to very briefly touch on the iRise, to give you a quick update, the city approved the $30,000 combat grant award in December, and so we have been completing the contract agreements with those agencies that have been identified to assist with this campaign. They will be handling multiple categories with the rollout of that campaign, specifically around brand and social media development, marketing, and of course, evaluation of this campaign. The campaign does include the city objective for public safety, which is using a public health approach to create PSAs by midsummer for gun violence survivors. So again, when we're talking about changing the narrative, we're saying being a gunshot victim, we're really talking about survivor stories, as well as the curfew truancy and the marijuana convictions consequences. So that is something that the Violence Free KC Communications and Marketing Work Group is working with our communication staff, as well as with the youth ambassadors. The Violence Free KC Community Survey. The goal of this 4-question survey was to help determine the strategies for the KCMO Youth and Family Violence Prevention Plan, because we believe that the best solutions come from listening to those who live within those communities and the experiences. And we really looked at this was to be a citywide initiative. And so we have collected over 10,000 responses to this survey. The quick slides, and I will run through them very quickly, but we were asked to give a snapshot of at least what we had. So what you're going to see next is data that was collected from 6,426 responses that were entered online. And so we are still doing data entry, so it will be some time before we have a full report. But if you look through this, the 63.3% we received from District 3, but we did get representation from other districts. In the next slide, you'll see that most of those who participated identified as community residents, but we did get about 12% from youth. And it should be noted that we did collect hard copies from some of the schools, and some of those youth identified as community residents, which is a good thing. But for the integrity of this survey, we made sure that what they checked is what we entered in terms of data. So some of the youth appear actually under community resident. And then looking at the next few slides, just very quickly, we're talking about community violence, which did include neighborhood, so gun violence as well as school violence. 56% were extremely concerned. The next slide was around intimate partner violence, which included dating violence, stalking, sexual violence, intimidation. 39.7% were extremely concerned. So as you can see, there was concern and extreme concern across all of the multiple forms of violence, not just community gun violence. So under sexual violence, which is attempted rape or forced sex without freely given consent, it was 46%. We're extremely concerned. The next slide is child abuse, which included all types of abuse and neglect of a child under the age of 18 by a parent, caregiver, or a person in a custodial role. That was 50.6%. And then the last one, which is bias-motivated violence, which included hate to discrimination based on race, color, class, religion, age, mental or physical disability, sexual orientation, gender, or gender identity. And in this case, 51.3% were extremely concerned. Again, this is just an overall snapshot until we get all of the data entered and fully analyzed, which we'll do at a later date, give you a full report.
However, one of the things, because we are a part of the systems approach, is we wanted to invite a couple of our system partners to talk about what's happening for youth and activities in the summer. And so we'd like to bring up first our partner with the Kansas City, Missouri Public Library, Lauren Osen. Next slide, sorry. We went just slightly out of order.
Good morning. Thanks for having me. I wanted to start off with letting everyone know that our summer reading program is going to kick off on May 25th. This is an all-ages program. Adults can participate as well. So we're hoping that families will be reading together with their children. And some things to keep in mind, specifically for our young people, every child and teen who signs up for the summer reading program will receive a book. So they can start a summer with a book if for whatever reason they may not have a library at home. Maybe they've had to leave their books behind after being evicted. So we're trying to remove that barrier to participation in summer reading as a program. But then also children and teens who sign up for summer reading, we will be able to forgive any fines they may have on their library account. So maybe that is going to be removing another barrier to making them feel safe in the space or welcome in the library, so they may be more likely to come to some of the after-hour events that I'm going to very briefly touch on. We're going to be having video game tournaments at the Plaza Branch. There will also be a Youth Empowerment Summit at the Plaza Branch. Those are both 5 to 9 programs, so those are, the Youth Empowerment Summit is specifically going to be leadership opportunities, volunteer opportunities, building that sense of being a part of the community and finding your own niche with the library. And then we are also going to be continuing to have teen lock-ins across the community July 27th from 5 to 9 at our Blueford, Waldo, Trails West, and Southeast branches. And then at the Blueford branch, where I'm the youth librarian, instead of just hoping that we'll catch these teens as they're 13, 14, 15 and convincing them that the library is the cool and great place to be during the summer, I'm really focusing my efforts towards young families, and we have a play group that meets in partnership with Front Porch Alliance every Tuesday from 10 to noon, and bringing those young families in with their preschool-age children, showing them that the library is a safe place from the get-go. And I do a story time at 11 o'clock, which is where I'm going to be going after this. So thank you very much for your time.
Thank you, Lauren. If we could go 1, 2 back. Okay. We also like to bring up Ms. Marva Moses with the Hope Hangout to describe some things that are happening in South Kansas City.
Good morning, and I'm so sorry for being late. South End's a long way from here, and everything can happen between 107th Street and here, so I apologize for my tardiness. Hope Hangout is a youth hub in Southland that kind of supports the school district as well as the neighborhood of Ruskin Heights, Ruskin Hills, Stratford Estates, and there's another one I can't name off the top of my head. In essence, we are housed in Bethel Family Worship Center, but we are a complete and separate entity and agency from the church. We are open every day from 3 to 6, Monday through Friday, and on the weekends we are there all summer long from 12 to 6, offering those 3 programs, which is Youth for Change, Solo, Students Overcoming Life's Obstacles, which is a really interesting group of 18 to 23-year-old students that used to be in Youth for Change. And then the Lotus Project, which is an all-girls initiative, specifically around the girls who have been propense to violence in our school district. And we're also rolling out 3 more programs this summer. One of them is the TNT, Teens in Transition process that is typically held in the core. We've been asked to run a Southland version of it, and we are extremely excited because adding art and the art component to what we're doing at the Hangout is just going to lend itself to all kinds of new friends and partnerships. So we're excited about that. For those of you who don't know what that is, it is an 8 to 10 week summer program specifically geared toward the young people who are either involved in criminal activity or have been just recently adjudicated in a case or 2 or 10. And the point of it is to get them engaged alternatively for the purpose of creating a beautiful piece of art to exhibit at the end of the summer. TNT South will be going all year long, so we'll do our culminating art exhibit, but we're also going to do monthly meetings with that same bunch of students to kind of track how well they do throughout the whole school year with behavior as well as their grades. We're adding a academic component because we're not using just the young people who are in the system trouble. We're using young people who are in trouble academically as well. So we're focused on incoming freshmen from 8th grade and outgoing freshmen into Ruskin, trying to make an impact on how their GPA looks, their preparation for college, as well as their studies, or high school, as well as their study skills. So we're kind of, our group is a little, it's more purposeful than just, there'll be some who are in the system, but there'll also be dual academically challenged as well. The other two programs that we're offering are a reentry process for specific young people who are coming home from detention, who needed to be reacclimated into Southland, or at least school and other programs that are going to help them stay out of detention in the future. And then the Hangout has an awesome opportunity to host missions groups from all over the country. It's called Urban Plunge. They are a conduit for missions groups in very rural parts of the nation that want to do urban mission experiences. And so they come to Kansas City, they do their missions work, and then the Hangout hosts this group of people. For every trip, we do dinner and we do kind of just a sharing of experiences and culture. I've had people from South Dakota, the backwoods of Tennessee, and most of these groups are teens who are interested in meeting their peers that don't have the same experiences. So they ask questions like, do you guys really have shootouts every day? And because that's what they're hearing by virtue of the media. And so the point of the relationship is to tear down some of that stuff and really begin to build real healthy cross-cultural relationships. So did I give you enough? The Hangout's pretty busy this summer. I'm excited to say, but I'll let you know how it looks at the end of August. How crazy I look, anyway. Anything else from me? Nope. All right. Thank you for your time.
Thank you. And that concludes for the health department. But we do want to make sure that the concept of collaboration, systems approach, and resiliency and hope and healing are a part of our conversations from this point forward. We did have a couple of slides that we have thrown in to also highlight some of the community health and healing events, but we won't go through those. So hopefully they'll be posted online.
Okay, great. So that takes us through Objective 1, which is the longest in terms of just volume of slides. So moving into Objective 2, where we also have several strategies, which is to evaluate and identify areas of opportunity in the emergency response delivery system to ensure the best possible patient outcomes. And the first strategy here is about measuring the impact and effectiveness of the Kansas City Assessment and Triage Center, KCATC. And so we have Stephanie Boyer here to speak to that.
Good morning. Thanks for having me. Stephanie Boyer, Rediscover, KCATC. I'm the program director. So we opened October 31st of 2016, so we're about 18 months in at this point. This data goes through the end of March, so about over a 17-month period. So during that 17 months, we have seen 4,151 total clients. So we've been busy. This slide just kind of breaks that down into kind of the 6-month increments there. And then breaks out just our referral sources only come from the emergency departments that partner with us. Kansas City Police Department, EMS in Kansas City, and then we do have a few self-admits in there as well. So those are the only ways that folks get in through our door. The next slide kind of breaks down just a little bit further into those emergency departments and then from the different zones within KCPD. So you can see Truman Medical Center is definitely our highest ED referral, with Research, St. Luke's, and North Kansas City kind of falling right in line behind there. As far as KCPD, East Patrol and Center Zone are definitely our highest referral sources too. We are located at the corner of 12th and Prospect, so we are very close to both of those areas, so makes it very easy for them to bring folks by and drop off to us. So we continue to outreach to our Northland and Southland officers, really trying to encourage them to make that trip down to bring folks to us. So.
Stephanie, on that slide, talks about Truman Research, St. Luke's, North Kansas City, and others. Who's paying the bill? Is it all the hospitals, or is it primarily, what are the three major hospitals paying their share of the cost?
So every emergency room that refers to us pays a portion. So collectively, among all of the hospitals, it's $1 million towards the operating budget. And they broke that out between them based on the amount of people that they serve and the referrals that they expected to receive. So I think it ranges from about $25,000 up to about $325,000, depending on the hospital system. So this was just to kind of take a look just at this year thus far from January. We had the data for January is a little bit of a struggle because we changed data collection systems. And so we started January 19th entering everything into our electronic medical record. And so we also switched evaluators, so they're still working on getting some of that data out for the first part of January from the Access database that we were using, which wasn't the greatest. But but during that time period, just kind of a breakdown between over that system and across the board over the 17 months. MIN is primarily our predominant referral with 71% over that time, and that's ranged pretty much from 70 to 74% over time. We do have about 65% of the people that we do serve are homeless, and the presenting concerns are kind of broken out there, primarily mental health and then drugs and alcohol. And you can see some drugs and alcohol combined together. During 2018 thus far, with the number of folks that are brought to us from Kansas City Police Department, from EMS, and that self-admit, we capture any of those referrals that otherwise would have went to an emergency room. And so that's how we kind of start to figure in just some cost savings there, that we were able to divert that cost from the emergency room. So just in 2018, that was 265 clients, so resulting in about $600,000. I think over the course of time, we're getting really close to about $3 million in savings total on that. Case management, we have really grown over the 17 months. Originally, we were budgeted for 2 full-time case managers, as our intention, is to kind of bridge the gap in the community and get folks referred into those long-term services into the community for case management, for psychiatry, it's been a bit of a struggle. The wait times to get folks connected into those systems is extremely long. So it can range anywhere from 6 weeks to 6 months to get someone actually engaged, just due to the sheer number of people trying to enter into those systems. So because of that, we have definitely had to increase the case managers because they're having to follow them longer, because typically once people leave our facility after 23 hours or less, those case managers are assigned to them, and they continue to work with them in the community to get them engaged into those long-term services, into treatment, into employment, into housing, all of those kinds of things. Because that process has taken so long to get those folks connected, they've had to stick with those people for a longer period of time. So we're up to 6 full-time case managers at this point. So you can just kind of see the breakdown over those months with the case management assignments. So a lot of folks coming through really do need that piece to kind of help get them fully connected.
Stephanie, is there an area of referral that has on average, the longest wait times, or is it kind of across the board? Relatively long?
Right now, the longest wait time is at Swope. Yeah.
Why is that, do you think? Is it just the geographic center of the storm to some extent? They have a clientele or base of clients in that area that are more in need of those services, or is there some other reason?
I mean, I think it's partially, definitely, probably the amount of people seeking services. There's also a shortage of providers across the country, not just in Kansas City. So that's definitely a struggle that we all continue to, struggle with. So that longest piece typically right now, like at Swope, is for the psychiatry part of that. So largely that does have to do with the number of providers. So getting people to come into the community and really do that piece.
Okay, thanks.
So to all those kids out there, go to school, become a psychiatrist or provider because we need you. So this was just to really kind of capture, we've been working closely. We have a community-wide treatment planning team meeting that happens every month where we collectively bring in the police department, EMS, area hospitals, and ourselves in our hospital diversion program, and we really focus on collectively people bring to the table kind of a lot of high utilizers. And so we talk collectively as a group about how we're going to approach that person and what's going to happen. So this was just really taking a look at really kind of some of our collectively top 4 people that we have seen over this last 17 months. The top 4 kind of people that we had that were utilizing EMS, some almost on a daily, every other day kind of basis. So you can kind of see, we have 4 cases there. So the first side just really shows those amount of times that EMS ran those folks. So 78 times, 160, 111, and 61. And then in the blue there, you see in 2018 year to date where we are. So we've had some significant impact with these folks. And I would say that across the board, this really speaks to just a lot of the work that we do is very individualized with people. And unfortunately for every one of these folks that we kind of get diverted out, there's usually someone coming right up the ranks, taking their place. So we just have to continue working together collectively as a community and really focusing on how can we best help those folks. So then on the other side, you just really see the cost breakdown of those. So again, significantly, we've had some real impact, and largely because we've been able to build a relationship with those folks, and it took time. I mean, you can see those folks also visited us multiple times. And we've really seen that with a lot of the chronic utilizers, is that it does take 20, 30, 40 times of coming through the door and us continually trying to build that relationship with them. So we're continually having that conversation with EMS and KCPD of like, please don't get discouraged, keep bringing them. It does take time sometimes to break down some of these barriers and for us to really get those folks to trust us and work with us. So by getting those folks engaged in services and with a case manager and working on housing, and one we did actually petition for guardianship. And so that will obviously have a major impact as well. So this was just to share, recently our evaluator conducted a couple more focus groups. We had a couple last year, so these were just done in March, so they're very new. So just really focusing on what folks' interaction was with us, and so you can kind of just see they had a lot of positive things to say. We treat people like a human being, and I would say that really that's the premise of a lot of the work that we do. We don't have a magic wand. It really is just about treating people as a human, being respectful, and really just engaging with them and getting to know them. Lots of folks we hear all the time, that if it hadn't been for them coming through the center, that they would have been dead, and that they feel like it's really a lifesaver. And we really see a lot of folks when they come in, they just aren't really sure what's available to them out there. They're not sure what direction to even go in. Our previous focus groups also just really focused on how important it was to eat, to sleep, and then to be able to sit down and talk with somebody about what does that next step really look like. And then we just try to meet people where they are. And if they're ready to take those steps, we make sure and get those steps lined up for them. And if they're not, then we just remind them that we're here when they're ready, and we try again. So the things that they disliked was they wanted a larger facility, and they wanted to be able to stay longer. So.
So I think a lot of what Stephanie's covered, and then especially the client perspective, is kind of covered really nicely in this segment that was done on PBS NewsHour. And we're just going to play a short segment. It's 10 minutes. It's a great segment. Really covers, I think, the full breadth of this issue. But we've just pulled out a couple minutes to hone in on. But definitely recommend.
3/4 of the patients are homeless men. Most have both mental health and substance abuse disorders and no insurance. Here they sober up, have a meal, sleep. Nurses and counselors fill in gaps in their mental health care, directing them to the help they need. It's all voluntary. They can leave anytime they want. They have to leave after 23 hours, a limit that allows the center to operate as an outpatient center and help as many people as possible.
Everything we do here is to really bridge them into whatever that long-term need is. And so we'll continue to provide whatever it is that they need during that time. Whether it's medications, case management, housing, whatever it might be. Working with an employment agency if their goal is to get a job, whatever it might be for that person.
After leaving, caseworkers follow up on those needs, in many instances helping place them in transitional housing, a critical need.
I was worthless on them streets. I mean, worthless, I don't know what the words. One officer called me bottom feeder. That hurt.
61-year-old James Butler says he spent nearly 35 years on the streets, drinking and using cocaine, suffering from undiagnosed schizophrenia. About 10 months ago, a police officer picked him up. Butler assumed he was headed to jail again.
The next thing I know, I'm pulling up at 12th and Prospect at Crisis Center, which I didn't even know that's what it was.
After being evaluated, a caseworker directed him to a bed at Benilde Hall, a sober home for men.
I drug myself in that gutter, what I call a rut. Well, now I've quit digging that rut. I'm kind of slowly filling it back in, and it feels good to have people smile at you instead of step out of the way. It really feels good. And I couldn't have done it, I'm not going to kid you, without this place, without help.
All right.
Not far away, Cassie.
I'll stop it there, but that's the end of our ATC section. So if there's any questions.
Go ahead.
Thank you, Mr. Mayor. I was just waiting for the rest of it.
Suspicious.
I know. I resemble that remark. A comment and a question. The comment being on the intake slide, and I know we've talked about this before related to the number of individuals who come in through EMS, and I know we've had great changeover.
Yes.
In the last few months, the last couple of months, but really, and you're doing all right, Chief, just so you know. But I do make the comment that I think there is a great opportunity for more capacity to come from that EMS source, and so I just want to suggest that to the degree that we can get more involvement, I think it is to everybody's benefit to do so. The question is related to the state funding. I know part of what can happen after they come into the ATC is sort of that handoff that comes as a result of the funding that comes from the state. I know you didn't mention it, Stephanie. I don't know if you want to make your plea now, but I thought we should talk about that because they are a partner at the table as well.
Absolutely. Yeah, so part of how we do all of that follow-up with folks is from the state legislature through Department of Mental Health. We have a pool allocation that we refer to as flex funds. So originally, the first year that we opened, there was $2.5 million allocated to that budget. When year 2 came around, that got cut by 50%. So we've been at 1.25 million over this last year. Currently in the state budget right now, there is that 1.25 still in there. And it looks like there may be an opportunity to add $800,000 of some federal dollars back to that pool allocation. So we are very hopeful. So anything anyone can do to help push that along and get that money restored back in there. It definitely sort of had to change that second year, our approach. We weren't able to kind of help folks quite as long as we were that first year, really getting them that chance to get really on their feet. When, as Mr. Butler shared, when you've been sort of living this life for 35 years, expecting people in 30 days to sort of have it together and ready to take it on their own is a little bit unrealistic. So when we have that additional dollars, that allows us to be able to help folks more with housing and things like that for at least that first 90 days, and then really giving them that chance to make it on their own after that. So, yes.
Thank you.
Yep.
Thank you, Mr. Mayor.
You're welcome. Thank you.
Yeah.
I do want to compliment you on having very good signs, be able to read. You guys seem to be able to get it together. And Bill, I mean, the letters are big and easily seen, and bills are like, you have your son do that?
Of course. Granddaughter.
All right.
All right, and so that's officially a welcome to Bill. He's going to talk about strategy B under objective 2, which is about implementing GEMT. We just have one slide on that.
Good morning, Bill Galvin, Assistant Chief, Fire Department. This will just be a brief update on the long-awaited GEMT. We're moving along. We're finally probably going to see the light at the end of the tunnel. This has been going on for 3+ years. This project has. We believe now that in probably the next 3 months or more, we may have this program in place. Central Jackson County, Missouri Fire District will be the ones administrating for this side of the state. And also, we'll have training on this program for our employees for collections on June 5th, and I believe finance will also be in that. And that's the update on this, if there's any questions. Thank you.
I talked to the chief the other day, and maybe this is more you, Doctor, I'm not sure, about the program down at Manual. Are you familiar with that? The
Yeah.
training of the kids?
I'm familiar a little bit, but I believe the doctor has more information than I do. I know that the program is kind of getting a slow start, and the graduation success was very
Not good.
dismal. Yeah.
Okay.
I think we probably should bring it into some other areas, and the fire chief might update you on that. I believe he's going to the microphone now. But,
I'm here,
there
Mayor.
you are, Chief.
Hi, how are you? Good to see you. On Manual Tech, we are committed to as much training as we need to give these students a chance to succeed in our organization. We're looking at our fire academy this summer to do some retraining, and there's a hierarchical testing methodology that we really want to teach the students because we're not sure they've learned how the state-administered test for EMT and paramedic is given. So we'll be looking at that and hopefully get some successful graduates. We've already kind of carved out in the fire department some places for them to come to work.
Okay, good. And I told you that I would make some contacts with some folks to talk to the school part. What I'll do is I'll put them in touch with you in some form or fashion so that this can get ironed out on the school level.
You know I'm in for lunch.
Well, that's, you mind? Oh, okay. I just think, if Larissa, if you're watching on TV, would you schedule a long lunch for Stock Hill?
Okay, so strategy C is about improving our cardiac survival rate through a variety of different efforts. And I'm going to turn it over to our emergency medical director, but first wanted to just briefly show the slide on resident satisfaction with EMS services, which is always an indicator we look at. Fortunately, it's been very steady over time, high level of satisfaction. And we also do distill from that resident survey that about 13% of our residents report having used EMS. And that group is even more satisfied than the general population who may not have utilized it themselves. And there's also a little bit of difference geographically and on an income basis in terms of who ends up reporting using EMS, which I think will tie in very nicely with what Dr. Kearney will have to share with us. So I'll turn it over to her.
Good morning, Dr. Kearney. I'm the new EMS medical director here in KCMO. I'm from Kansas City, so very excited for the opportunity to speak to you guys. And I think it's a good place in the presentation to talk, as you guys have pretty much set up something similar that I'm going to talk about here. So I'll try to speak fast and we'll just get right into the data. Whenever we're looking at patient outcomes overall for an agency and comparing our agency to other agencies, there's a cardiac arrest registry called CARES that looks at cardiac arrest that is suffered in a community, all the different types of cardiac arrest, and then the points you look at for survival, ROSC being one of them. ROSC stands for the return of spontaneous circulation. So that means you have died, we show up, and we get a pulse back. That's all that ROSC means. That does not go into the neurological viability after you have died and then been brought back to life. So whenever you're looking at types of cardiac arrest, looking at ventricular fibrillation or ventricular tachycardia as the best case scenario. And the reason I say that is because there is something that we as fire and EMS can do for you. The other types of cardiac arrest, asystole or PEA, you're much less likely to survive. So whenever we are looking at benchmarking or looking at registries, a lot of people pull just the VFib and the VTAC because, again, we can address it, we can do something about it. So looking at our ROSC over the years, the return of spontaneous circulation with the best case scenario types of cardiac arrest, VFib or VTAC, it has been pretty constant, around 35% from FY13 to 18. ROSC for all comers goes down to 15%, but again, that includes all types of cardiac arrest, the asystole and the PEA as well. The target for fiscal year 18 increased from 30 to 40%, which we're pretty much spot on with. Next slide, please. Digging into the data a little bit closer, I'm not going to go through all of the data here, but I do want to draw your eyes to 2017 and the national average here. So on that first row, cardiac etiology with resuscitation survival rate, again, that's...
Pull your mic back a little bit.
Am I too loud?
No, you're not loud enough.
Is that better?
Yeah, you have to talk pretty close into it, I think.
So looking at cardiac arrest survivability by category, that's what this slide is, and I want to draw your eyes towards 2017 for Kansas City Fire Department, and then right beside it is the 2017 national average. So cardiac etiology with resuscitation survival rate, that first row is for all comers, all people who have died of some type of cardiac etiology. The national average in 2017 of survivability from that of ROSC was about 10%, and KCFD met that national average at about 11%. Bystander witness survival rate, so again, we start digging into a better case scenario. You die, somebody witnesses you die, and then they can intervene immediately. Looking at the bystander witness survival rate, because again, somebody is there to intervene, that rate goes up nationally to 16%, and then KCFD is right above that national average there at 17%. Unwitnessed survival means that, again, you have died and nobody has been there to intervene. That rate's going to be much lower, so both are about 4%. The Utstein survival is what EMS physicians like myself really like to focus in on. This is, again, best case scenario when it comes to cardiac arrest. It's a shockable rhythm, VFib or VTAC. It's witnessed, and then there was intervention with that witness there being bystander CPR or bystander AED use, which we'll break down in the next slide. The Epstein survival nationally, because of that best case scenario, is up. It's 33%. For KCFD, it's about 30%. And then breaking that down for an Epstein bystander survival rate, which would be a little bit higher, is 37% nationally, and for us, it's 33%. So I came into the office about 5 or 6 weeks ago, and I pulled our 2018 data, and that was the data that I was the most ignited by to talk to fire chief and our whole department. The data is very limited because it is a registry, so you can't make any statistical significance based off of it, but we can just kind of show you where we're at. So again, just starting at the top in 2018, so January to March, the cardiac etiology with resuscitation survival rate for Kansas City was 3%. Nationally, again, in 2017 was about 10%, and nationally, it is looking to be about 10% again for 2018. Again, it's still really early to tell. Bystander witnessed was down 5%, unwitnessed 2%. The Epstein survival, which is the one we can intervene the most on, and then the Epstein bystander survival, again, the best case scenario, we're down to 0% so far. So in the month of March, when I took over in April, looking at the month of March, if you died in Kansas City, you stayed dead. So let's dig into this just a little bit more and kind of hear about why I think that is.
Before you go there,
Yeah,
when you're looking at the 2017 national average, is that if you looked at it quarter by quarter,
Right.
would you see fluctuation
right.
in those numbers such that we shouldn't be overly concerned about the first quarter? Or is the fact that the first quarter here is only 3% a cause for genuine concern? I mean, this isn't a matter of an accounting situation where
Right.
money is coming in at various times and that has an impact. So
Yeah, that's a very good question. So the data overall is a registry, so it can be adulterated in the sense that you can record whatever you want whenever you want. So it is very tough to draw any clinical or statistical significance based off of a registry in and of itself. The registry is, EMS as a whole is pretty much new when it comes to science and reporting, and the CARES registry on top of that is also new as well. So who is recording and when is a factor. Also, the numbers for March were very, very, very small.
Okay.
And so if you have one death out of that end being so small, it's going to vastly affect your percentages.
Gotcha.
So
Okay.
as a physician, I do not draw any statistical significance based off of this. What I do use this for is to ignite discussion on the next couple of slides that we'll talk about.
All right.
So the big comparison, when we look at neighboring agencies, that sticks out to me as bystander CPR rate. A neighboring agency has a bystander CPR rate of 66%. Here in Kansas City, a bystander CPR rate is about 30%. It stays around 30%.
What's a neighboring agency?
Do you want to know the name?
Well, yeah, I do.
Johnson County.
Okay.
Yeah. And so their average patient age is about 80. Our average patient age is about 40. We're going to talk about the differences in our patient populations as well. The next slide, please, is this goes along with bystander intervention, which is the automated external defibrillator. And again, it's below the national average. So to get to the mayor's questions on the next slide, we don't have to reinvent the wheel because this has been studied before. I'm going to present a few different studies. We won't go into all of it. I won't begrudge the details, but it has included Kansas City as well. I like this study here called Strategies to Improve Cardiac Arrest Survival, A Time to Act, mainly because it involved all of the heavy hitters. It was a big committee on the treatment of cardiac arrest, the current status, and future directions. It was a study between the National Academy of Sciences and the CDC, National Institutes of Health, the U.S. Department of Veterans Affairs, and it got support again from the heavy hitters, the American College of Cardiology, the AHA, and the Red Cross. So just a couple of slides on this study. For background, we know all of us at some point will die. I hate to say it. 4 out of 5 cardiac arrests will occur at home, though. Over 90% of those cardiac arrests will die before they reach the hospital. So that means that cardiac arrest treatment is a community issue and something that, as an EMS physician, I will continue to focus on. So a goal will be shortening the time between arrest onset to the provision of care. That's paramount. So why is there such a difference between us and our neighboring agency when it comes to bystander intervention? We know that bystander CPR rates vary by income. This has been proven time and time again by multiple studies. Studies show that, excuse me, I'm a slide too soon. Studies show that the low-income neighborhoods have lower rates of bystander CPR. This has been shown in King County, in Canada, Georgia, and then our own National Cures data set showing that bystander CPR rates increase with median household incomes. So the more income you have, the more likely you are to get bystander CPR. Next slide, please. Also, bystander CPR rates vary with race and ethnicity. These studies show that Hispanic, African American, or poor populations are 2 to 3 times more likely to have out-of-hospital cardiac arrest, so more than likely to die outside of the hospital. But African Americans and Hispanics, time and time again on studies, have been shown that they have lower rates of bystander CPR. Next slide, please. So this big study in the New England Journal of Medicine that included my mentor, Dr. Salamone, and then Dr. Chan, who we'll talk about on the next slide, showed that in neighborhoods where household incomes were greater than $40,000 and greater than 80% of the residents were white, 37% of those people received bystander CPR. On the other side, when the income was less than $40,000 and greater than 80% were black, only 18% of those people got bystander CPR. The Kansas City Star interviewed Dr. Salamone and Dr. Chan on this in 2012. This is not a new issue. I like Dr. Chan's interpretation of the data best, so I will say his quote here. "It isn't race or wealth that makes people more or less willing to help save a life. It's most likely how prepared or unprepared they are to do it." We know that people here have the desire to help and improve when it comes to our agency, but also our community. Spatial epidemiological clustering techniques are being utilized by different EMS agencies now, so that way they can identify high-risk neighborhoods for a higher incident of cardiac arrest, but a lower provision of bystander CPR. We can do this here and use this to target our community education and resources with something that is more statistically significant than a CARES or a registry data set. So the goals for my medical director's office, again, I've been in there for about 5 weeks now. The first thing is to improve our CARES data collection. Being a registry, again, that it can be adulterated data, it is important that we continue to focus on our hospitals providing outcomes, so that way we know if these patients do survive, and if they do survive, what their neurological activity is. As an EMS physician, that is a new subspecialty. There's about 2,000 of us in the nation. I have connections with our EMS president of our national board, because that's where I went and did my training at. Reviewing and implementing pre-hospital evidence-based medicine here in Kansas City, our standard has to be elevated to include evidence-based medicine, and that's my goal and my drive. Updating protocols, procedures, and policies. Since I've been in-house, a big shout out to my assistant paramedic, Michelle Shearer. We have updated all of the protocols, procedures, and policies. A lot of them had not been updated since 2003, and they were grossly outdated when it comes to medical care. So as a base, we have to fix the basics. And as the new medical director, our goal is improving the science here, improving the medical care here, and then a final point in coordination with Fire Chief Gary, improving our continuing education, because medicine overall is based on continuing education. I've had nothing but support from the fire department and Fire Chief Reese when it comes to that. And then the next one is the next strategy that I will also talk about, but we can.
Any questions before we move on to the next strategy? Yeah, she's gonna.
I got a question
Yeah.
for you guys.
Can you hear me okay now? Can you hear me okay now? That
What
I-
if we were
We
to?
could, as long as you were talking into the mic.
Okay.
What if we were to take our, and this is a question for fire as well as Dr. Carney, what if we were to take our lowest life expectancy neighborhoods as generated by the health department?
Right.
And spend the summer and fall doing some community-based
Training.
CPR training.
Perfect.
At community centers or something like that. I'm sure we've got some volunteers that may be on modified duty that could help us with that work.
We are planning to tap into an unused portion of our department. In collaboration with labor, we look to have some people freed up very shortly, and community paramedic initiatives. In tandem with Dr. Carney's excellent work, we really do plan to start interfacing with the communities in ways we haven't before.
Let's do that. Let's put together some programs this summer and training sessions in those targeted areas where we might have an impact on.
Right.
I have another idea about that. I think that as we're getting people in the community trained, everybody who works for the city ought to be trained.
Yeah.
You know, that's, to me, that's ground zero.
Yeah.
Hard for us to talk about other people being trained if we're not.
Yeah.
And I frankly think that we ought to be doing that at least simultaneously with community training, if not before.
Yes.
Okay?
I agree, because as the studies have shown, this is a community issue.
Yeah.
If EMS shows up 10 minutes later and no bystander has performed intervention, the rate of survival goes way down.
Yeah.
That being said, on our side of things as well, in working with Fire Chief, the continuing education is undergoing a massive change, creating more simulation for our providers instead of lectured PowerPoints, moving more things online as well for 24/7 access. And then having scenarios, potentially quarterly, with one of the scenarios for our providers always being cardiac arrest.
Yeah.
So having our crews constantly going through the cardiac arrest.
Yeah. Well, I've seen Troy so apoplectic at some points in the last couple of years that I've been concerned, and I have a vested interest in making sure that he survives until at least July 31 of 2019. After that, somebody else's problem.
Mayor, can we get that date again? We need to target that. So.
July 31, 2019.
Thank you.
Okay, so we'll move on to strategy D. I love that I'm sitting beside Stephanie here, because this does talk about our high utilizers and another focus of my office and the fire department. So, we know EMS as a whole is changing. EMS, by definition, is at the intersection of healthcare, public health, and public safety. So my job as an EMS physician is no longer just healthcare like it was at Truman and the ER. We know with this, there's an expanding role of the paramedic. No longer is the paramedic expected all of these 911 calls, you show up, you treat, and you transport. Now it is turning more into the management of these low acuity chronic illnesses. Monitoring these patients at home potentially, and then preventative medicine, preventing ER visits, which is a brand new thing for EMS providers. There is data out there on certain programs that have made this transition successfully, looking at Canada, Australia, and England, and since the past year also includes the United States and a couple of states here as well. So I pulled, with the help of, again, Michelle Shearer and Mike Latta, our high utilizers of the 911 system here in Kansas City, Missouri. This is just looking at the numbers of the high utilizers. A lot of them overlapped with Stephanie and KCATC. A few of them did not. The top 10 users in 2016 were transported 1,200 times out of about 95,000 transports.
10 people.
The top 10 users, yep. And then the top 10 users in 2017 were transported. This is not how many times they've called totaled, it's just the amount of times they were actually transported, over 1,000 times. The highest utilizer in 2016, and these are my people. I have high respect for these patients. I'm just laying out the data here. So there's no assumption about the patients that we're talking about. The highest utilizer in 2016 called over about 134 times. A different high utilizer in 2017 called about 160 times. This is calling 911 and being transported. I want to focus on the locations from which these high utilizers called. In 2016, the highest utilizer called from 70 different addresses. In 2017, that different high utilizer called from 50 different locations. And then from the medicine side, I wanted to see what their chief complaint was. 47% of the time it was abdominal pain for the high utilizer in 2016. 90% of the time it was for alcohol intoxication in 2017. And then because I'm an ER physician at Truman as well, I wanted to see how often they were brought to Truman. 72% of the time the high utilizer in 2016 was brought to Truman, and out of that, 100% of the time was discharged. 44% of the time for the high utilizer in 2017, and then again, almost 100% of the time discharged from the ER. We'll talk about the significance of that. The second highest utilizer called 133 times in 2016, and then a different high utilizer in 2017 called 145 times. Again, a high number of different call locations, close to 70 on the second highest utilizer, and then over 30 on the second highest utilizer in 2017. Both times, the majority of the 911 utilization was for alcohol intoxication. They were transported to Truman a big chunk of the time, and then again, almost 100% of the time discharged from the ER. The third highest utilizer, we won't go through all 10 on both sides, but the third highest utilizer, again, called 131 times from over 24 different locations. Alcohol intoxication was a big reason for the call. 21% of the time was transported to Truman, and at Truman was discharged almost 100% of the time. And then the final third high utilizer in 2017, they called from 67 different locations for alcohol intoxication. 67% of the time they were transported to Truman, and again, almost discharged nearly 100% of the time.
So
Yes,
you've got a number of locations, different locations, but is there one or two locations that seem to predominate?
It was all over the city.
Okay.
Just like her data with KCATC, there are certain areas where you're going to find more of those patients, like along the avenue, Independence Avenue. And a lot of these patients, when they did call, and it was multiple different addresses, it's just a few streets away from where they did call. Around the Union Mission, stuff like that, or some of the higher places. You can ask any of our crews and any of PD as well, too. Hey, do you know where so-and-so is going to be? And they'll tell you, yeah, he'll be at the 7-Eleven from this time to this time, and I expect he'll be calling then.
Okay.
So what's the impact of this? I like what Stephanie was saying, because if you focus on success for high utilizers, you have to be careful with how you define success. The metrics of success for these patients is not easy, and it's multifactorial, and every single patient is going to have a different management. So it does take a certain approach to a certain patient. There's not one easy answer for all of this, but we can start to ask good questions. If you look at money or cost, which is not my area of expertise, you can start to pull some numbers together. For instance, if an ER visit is $1,000 and an ambulance ride is $800, for the top 10 users in 2016, that's about $2 million that we're looking at. That being said, not all of this care is unreimbursed. Some of this care can be reimbursed. I like to look at it more from resources. This reduces our availability of units and fire trucks and personnel and morale. The more they run these chronic utilizers, the less they can be ready for those 911 emergent calls. So I like to look again more from a standpoint of the resources than the actual money.
Just a question.
Yes, please.
I think the lists overlap. Have we put the
Yes.
two lists together? And
Yes,
have they?
yes. And we've also put that list together with Truman because, again, that's where I work, that's where I'm employed. Out of the top 10 utilizers in the city, and excuse me if you got something to.
Go ahead.
With Truman, about the top 6 overlapped. With the good work of the high utilizer case management team that Stephanie was talking about, the top 4 or 5 have fallen off of our list for 2017. So they are already making an impact when it comes to
Good.
EMS, emergency departments, and our fire department in general. That being said, there will always be the next 10 that come in to play, exactly like Stephanie said. So even when you compare the list of 2017 to 2016, the top 10 names have changed. They're not all the same because they have made a difference in collaboration with the surrounding hospitals and SWOPE and everybody else who's involved.
Good,
So-
keep at it.
So, this can't be a problem unique to Kansas City. So what are some of the strategies that have been made to address that?
Yes, I like that transition.
Oh, okay.
But before we get to the strategies to address it, the quick
I
potential.
just wanted to point out to Mayor Pro Tem over there that I transition well.
You do transition well,
That was a beautiful transition.
but I can't wait to hear what she says because we've talked about this a few times, so.
Yeah. So just a really quick, to help answer the question, the barriers to change. So unfortunately, reimbursement for ambulance services by Medicare has been limited to when the ambulance transportation is provided and medically necessary. So every single time our crews get called for these high utilizers and they're not transported, or it's not a medically necessary transport, then we are losing units without reimbursement. And that's assuming these patients have that insurance as well. The other thing that has sabotaged us previously, I see us EMS as a whole. Again, it's a national problem. It's not just Kansas City. The previous definition of what is an emergency is what a patient has defined an emergency as. So in the court, if a patient says it was an emergency, although the ER doc says it wasn't, if my crews were to not transport that patient, they could get in trouble.
Right.
Right? There has been a target on the False Claims Act and Medicare fraud and abuse recently as well, which just goes to show the patient must demonstrate a need for ALS, meaning the patient has an abnormal vital sign, a need for medication, in order to qualify for ALS reimbursement. So even if we transport these patients, doesn't necessarily mean we'll be reimbursed. And if we charge these patients incorrectly, we could actually be in trouble for fraud. Again, focusing on the average different number of locations, these patients a lot of times are undomiciled or homeless. They're calling from over 30 different locations on average, and that's just the average because as you saw, some are calling from over 70 different locations. And it can be anywhere north to all the way south, east to west. And then my personal favorite, looking at the science that's out there, although it's limited, studies, including one study done by my boss, Stellar, Dr. Grattan, shows that pre-hospital routinely in the past has under-triaged patients. So EMS physicians have been nervous about letting our pre-hospital personnel refuse a patient. Showing our data here on our high utilizers and why I looked at 100% of the time they were discharged from the emergency department. We're working with the residents at Truman Medical Center to publish a couple of papers that basically say, hey, these patients were discharged without intervention. Nothing happened. They don't necessarily need to be transported. And so we are fighting the public perception. You call 911, you get lights and sirens. We are fighting the federal definition of how we get reimbursed. As a national organization of EMS physicians, we have gone to Washington, D.C. and said our EMS providers, their role is changing. No longer do we treat and transport everybody. Now we can make home visits. We can use community paramedicine or mobile integrated healthcare or personnel on modified duty to visit these patients before they even call 911. We are looking to change the definition of the scope of practice of a pre-hospital provider, meaning that they're not limited to just treating and transporting. They can actually do appropriate medicine with these chronic high utilizers.
Okay.
Yeah.
Good. Cool.
Yeah, and then working with places like KCATC, there are a few studies coming out across the nation looking at sobering centers as well and the safety of sobering centers, so.
Great. Well, that takes us to the end of Objective 2, and rest assured, the next couple objectives are pretty short, so we're actually not behind on time. So Objective 3 is about improving diversity of employee recruitment, succession planning, and retention in our public safety departments. And the first the first couple of slides here are just updates. We have showed these a couple times, I think, that just sort of summarize personnel diversity in our two public safety departments, our two uniform or sworn. So KCFD, and you see up top the uniform percentages. blue is male and green is female, and then broken down by races, and then bottom is non-uniform. So looking at the uniform specifically, which is defined here as members of one of the two fire unions, they are, KCFD is 29.11% female and or racial minority as of April, which is roughly where we were, I think, last year at this time. And then for KCPD, this is as of their board report in February. And so again, this is looking at sworn versus non-sworn, same basic breakdown. And in terms of the sworn breakdown, looking at 33.51% female and or racial minority, which again is pretty similar to this year this time last year.
But the highly skewed in the non-uniform areas, okay? If it wasn't for the larger percentages of black females and white females in the non-uniform category, then the numbers would be fairly dismal.
Well, so the breakdown, they are broken down separately. So the sworn up top, the 33.51, that is just sworn. So it's adding together white females, black male, basically everything. Yeah,
Okay,
the inverse
yeah,
of that.
I
So
see
down
that.
below, yeah, the non-sworn is, and that's the case in both.
But to your point, Mary, there's your non-sworn numbers.
Yeah, the non-sworn and the non-uniform numbers are flipped.
Totally, well, of course, they are. And there's a lot of reasons for that we don't need to get into, I think. But, 33.51% of females and or racial minorities is still not very good when you consider the makeup of the communities that are being served. The number looks better than the reality, in my opinion, but that's just me.
There are two strategies under this section. First one is about implementing the recommendations to the KCPD staffing study. And so just have one slide in here that on the right you have, this is pulled out of the presentation of the staffing study from last year, but just updating what was actually done in the FY19 budget, adopted budget, in comparison with what the recommendations that came out of the staffing study. So the staffing study recommended a net increase of 58 positions, which is really an increase of civilian and a decrease in sworn. The adopted budget includes a number of additional FTEs, 15 dispatchers, which are civilian, 23 sworn, and then the 10 parking control, which came as a result of the parking agreement, which I think postdated the staffing study. So.
And I think, Kate, I just looked at those 10 parking control are non-sworn.
Oh, they are non-sworn. Okay, that's my error then. Sorry. So if there are any comments there, we'll go on to strategy B, which is developing partnerships to increase number of entry-level public safety. And so we did already address, we don't have a slide on it, but did already address the pre-apprenticeship program as being an area of investment that KCFD is making. And then we also have another slide in here that just speaks a little bit to training generally and how that's being carried out.
All right. We had the trainer had been conducted on the 43-foot Class A burn trailer, and we also have a 43-foot multi-skills trailer, which has a entanglement drill and several others in there. I think there's 41 different stations in this simulator. Also, the driving simulator had been moved to 108. This throws out scenarios for driving that you may not be able to do while you're driving down the road. Of course, something can't jump in front of you, or you can check while running an emergency. You can judge a person how on he runs, whether he'd run a stoplight. But this scenario puts those into place. This is in 108 now. We believe everybody has been trained there in 108, and it will be moved to 103. It should probably be close to being moved now. I don't know that everybody's been trained all the way in 108 yet. Both the Class A and skills trailers have been utilized for firefighter training, include company officer and firefighter recruit academy. And also we have the what's called the Target Solutions program. It's a web-based training program We don't have to bring everybody down to the academy. It can be done over the internet. That's why we have all the Google Fiber in the stations now. There was 1,287 personnel uploaded into the system, and I'm happy to report that all 1,287 have been trained to use the Target solutions. We have logged over 64,302 hours of training since July 1st of 2017. There has been 18,242 courses that have been uploaded into the software program now, and like I said, this is all web-based. A lot of this has to do, it's a savings of fuel. When you can bring the trailer up to a district, have them meet, they can train with that district most of the time that they'll be responding with, so everybody learns together and knows what everybody's doing on them training situations. Also, it's able, the live burn trailer, it's able to free up the academy when we have a cadet class in there, so we can move them live burns out to the districts that they need to be moved to. And that's all I have, if you have any questions.
Okay. Moving on to Objective 4, which is about increasing effectiveness and efficiency of operations at municipal court in order to achieve best outcomes for those served. There are two strategies here, and so we'll talk through turn it over to Megan Fantasyl to talk about the first one, which is measure the efficiency and effectiveness of municipal court.
Good morning, Megan Fantasyl, Court Administrator. The first we listed is the 10 performance measures from the National Center for State Courts. This is something that, nationwide, they look at municipal court, or they look at all courts. I have picked out, we currently handle 2 and 3, and 1, 7, and 9 tend to be more survey-related indicators, and so we are actually looking at implementing those in this next fiscal year. But we'll just go in through some of the things that we do look at. One of the major ones is our case clearance rate, and I will show that we've had a dramatic drop in this last fiscal year. That could be attributed to two different reasons. One, we had a judicial vacancy for several months, and two, the police officer citation volume has increased. And so with more tickets being issued and less tickets being able to be docketed each month, our case clearance rate did fall quite considerably. However, we have a new judge who took the bench on her own in April, and so we are hoping to get those numbers back up closer to that 100% mark. Some of the other things that we track is the percent of traffic cases payable within and disposed of within 90 days. Again, that's kind of goes with the same thing. If the cases can't be docketed, we can't dispose of them. But some of the things that are trending up is that we are able to, with our Qmatic line queuing system, we're able to tell that the most 91% of our customers are served within 10 minutes at the Violations Bureau. They're not having to wait ungodly amounts of time to be served, to pay a ticket and to leave. And the other thing is our percent of clients not incarcerated, again, within 6 months has gone up to 95%. And I think that goes along with the next one, with the percent of probationers successfully completing probation conditions. We're actually looking at the reasons that they are coming in contact with the criminal justice system and finding programs that they can successfully complete that will keep them out of being incarcerated again. I think that's the drive for our municipal court, is to make sure that we are reaching the individuals who need the help and getting them the help that they need so that they can be successful and not back into our criminal justice system. Well, I was hoping to have some newer sides of the east side of our building renovations done, but there's a little bit of a delay on that. I will, though, highlight some of the remodel again. We're really focusing on the customer experience at the municipal court. We want to have people come in and feel welcomed and like that they're going to receive fair justice. So although they may not be happy about having to come to the court, they can at least have a good experience while they're at the courthouse. So next slide, we'll go to strategy B. So this year for our strategy B, we really looked at refining our drug court standards. Our drug court program was struggling a lot with our numbers. We were not reaching the people that really needed the help the most. So we brought in some technical assistance from the National Center from State Courts, as well as from SAMHSA, that helped look at our drug court program. So based on that, we have revised our eligibility requirements, and that really impacted our numbers. So we've had 81 assessments for drug court, and 63 new drug courts have been signed. We have 36 drug court participants that are currently active, and we have 13 on target to graduate in August. So we were down to about 3 graduates every 6 months, and now we're looking to actually graduate 13 individuals. So that is, thanks to looking at, our barriers to what was getting them into the program, and revising those requirements to make it available to more people. But I will, so we've had, great success with that. I still want to highlight, some of our other courts. We have our Veterans Treatment Courts, and they are really working on just maintaining that partnership with the VA and getting those services for those people. Our Mental Health Court is still offering services for in and out of the detention facility, and working with all of our partners on there. We have really expanded our truancy court programming. We are now providing incentives and additional services to participants, really trying to get those families the services that they need so that they can make sure that their children are in school.
Megan, give me an example of an incentive.
An incentive, we do a lot of like $5 gift cards or sandwich, like a free meal. Movie passes, we're working with AMC right now to get movie passes, some, kind of pro-social activities for these families to do. So that is, if the kid comes back and their attendance has increased, then they are able to get an incentive. And again, our domestic violence court, very proud of that. We've been kind of named the model domestic violence court through the state or through the nation for the Violence Against Women grant. And so we have courts coming in all over to look at our municipal municipal domestic violence court. And our compliance docket in particular. We're really looking at those high offenders that have a very, their likelihood to reoffend is great. And so our compliance officer is really working with them. The judge sees them on a weekly basis. They still get drug tested, and they are working on batterers intervention classes as well.
Okay, that takes us to the end of the objective on municipal court. Questions?
Yeah, question. Megan, can you go back to your indicators? Because I do want to ask regarding the case clearance rate.
Yes.
I'm a bit surprised that it's fallen as it has, and I understand the reasons you gave, but I guess as we have talked over the last 2 or 3 years, as far as the citation volume, and of course I even, as I am silly like this, made the case that based on that citation volume, I wasn't even sure we needed to replace the judge, who was going to do a wonderful job, and she's going to be great. But I guess what I'm trying to understand is both in terms of how that citation rate has climbed, but also understanding that whether or not that there are individuals who are actually taking those citations to court, in which case you would need to have someone adjudicate them. So can you kind of talk about what's going on there?
Well, like I said, I was actually really surprised with the amount of decrease in the numbers. But I will say all cases get a court date, no matter what, no matter if they ask for one or not. They are going to be summoned to a court date. And that court date, if we don't have that availability, gets pushed out a little bit. So they are not getting that because we have less dockets to fill. Those cases are getting pushed out a little bit, and so they're not getting heard necessarily in that time frame.
Is there any concern, because the citation drop is substantial, and so I guess my concern based on that is if we actually start seeing rises and they don't even have to approach what they were, is there any concern then that we won't be able to handle a certain volume of citations for the reasons you just mentioned?
I don't think at this point. I think what will happen before we get to that point is we will look at how we docket our cases a little bit closer. We've been able to keep our docket numbers a little bit lower because of the citation volume. Obviously, if that does begin to increase, then we'll have to look at that and look at the numbers that are allotted for that court time. I think it'll be something that we will definitely look into if citation volume continues to increase. I did notice, I just got some preliminary numbers this morning for April, and they seem to have kind of leveled off a little bit. I don't think we'll see that increase as much, but you never know. We'll handle it if we get to it. I will say something that is very interesting in my mind as I go to trainings for the state of Missouri. They do not want us to talk about our case clearance rate or the number of cases paid within a certain time frame. In fact, they have what they call a Supreme Court monitor who was appointed after all of the legislative changes with the municipal courts, and we actually have a little bit of a disagreement on how we monitor our caseloads and how we docket our cases. She believes that we need to let everyone miss a court date before we actually send them another notice, another invitation to court, another summons to court, and then we can issue a warrant. Obviously, if that was the case, we would have to, our numbers would definitely go a lot longer for case disposition. Our numbers would, our number of cases that have to be docketed would just double, and that would not be a good thing. I work with the judges to make sure that we are following the law and we are making sure that a defendant is receiving or summons is being mailed to their last known address before a warrant is issued, but I don't think that we need to necessarily give them a chance to miss court before we actually issue a warrant. So if they do not appear on their first court appearance after they've been mailed a summons, they will get a warrant. Now, our judges have been very accommodating to defendants with our new walk-in docket policies. And this may be something that, like you said, if case volume goes up, and we may have to do away with those walk-in dockets. Right now, we have a judge set aside either a morning or an afternoon where anyone with a municipal court warrant can come in and talk to a judge. Now, there's no guarantees that that judge will set aside that warrant, but they will have a chance to appear in front of the judge and say why they did not appear, and the judge may or may not recall that warrant and give them a chance to appear again. So we do those things to make sure that the defendant does have that access to justice and that they have those opportunities to see a judge.
Very good. Thank you. Thank you, Mr. Mayor.
No worries.
Okay, so that takes us to our final objective, prevent animal-related threats to public safety and support animal welfare. There are 3 strategies here. The first one is about increasing the percentage of licensed pets, and so I'll turn it over to Patrick Egbury.
Well, first of all, thanks for saving the best for last again. Appreciate that. Good morning, Mayor.
Pull your mic up a little bit.
Yes, sir.
There you go, thank you.
All right.
There you go, thank you.
Thank you, sir. Strategy A, partner with Spay and Neuter Kansas City. Mayor, once again, we continue to partner with SNKC. Last year, we had a contract, actually requires them to hold 2 satellite clinics, and they end up with about 7 clinics, which is good. This year, we have a new contract with them and calls for 5 clinics, so we are hoping to get about 10 out of 5. Just keep our fingers crossed.
All right.
Yeah. And part of the efforts we're putting into increasing license sales, we will be, this week, we have 4 interviews, interviews scheduled to hire about 4 interns. What they will be taxed to do, making phone calls. First of all, they're going to learn all aspects of pet licenses. Then they will be making phone calls to people who obviously had licenses and let it expire, just to let them know, hey, you still need to go and renew your license per se. And we'll also have them come up with ideas. You know, young people always have good ideas to see what we can do to increase license sales. So we pretty excited about that. We're looking forward to getting the best and the brightest from the internship list. Okay. If I may turn to slide 106. I think 106 goes with the very first slide, if you don't mind. Okay. This, if you look at the numbers there, forgive me, folks, all these numbers don't add up. It's basically showing 3 clinics for 2018. It's inclusive of those, the total numbers are inclusive of all the clinics for fiscal year 2017. So it would be from May 1st to April 30th this year. So that's where you have total vaccinations that SNKC did, 1,060. Look at the Microsoft, I said Microsoft. Microchip sold 740. Total licenses sold 1,054. So once again, they have been, in terms of helping us increase license sales, they've been pretty good partnership in this endeavor. So we thank them.
Thank you.
Okay. Slide 96. This numbers pretty much shows number of KC pets with current licenses. You know how people get licensed to drop off per se. So we try to capture those that purchase license and actually still have them. So if you look at that right there, 24,547 cats and dogs licensed as of March 31st, 2018. That's a snapshot for the numbers for licenses in Kansas City. Our goal is to get those numbers up, so we'll do everything we can. Like I said, utilize all tools at our disposal to try to get those numbers up. If we can get it up from 11 to, I know it says 11 to 20. I don't know where 20 came from, maybe from my boss, but if we can get it up to 13, that would be wonderful. So we'll do everything we can to get those numbers up.
Patrick, on that, I noticed the decline, that we kind of peaked out in 2016. And now we've fallen off, at least on dog licenses. Was there a change, or did we do something in 2016? I'm trying to remember, but it's all faded into the mist for me now, but it shouldn't be that. Did we do something in 2016?
Not necessarily, though. We've been, through SNKC and through other collaborative efforts in terms of calling staff, internally calling the enforcement list, those who failed to renew their licenses. I can't recall anything we pretty much did differently.
Well, if I might interject, at one point, and I thought it was around this time, we did do some door-to-door work, did we not? We did some targeting work.
That was 2010.
Was it? No, it was while I was on the council. I know we did it. Yeah, I wasn't around.
It's usually a really popular thing for us.
Yes, because I remember all the emails I got at the time. So I'm over that trauma now, actually. So.
You know, Councilman, we'll be glad to do it again.
We're all
with
team
your
players
blessing.
here.
Yeah.
So.
Hello,
We'll
Deletta Dean.
get the emails.
I'm sorry, Deletta Dean, Deputy Director, Neighborhood and Housing Services. Patrick, you can speak for yourself. I don't know if I advocate necessarily going door to door. Mayor Pro Tem, I believe we did some outreach to the vet clinics during that time. That's when we were working to increase the number of vets that would sell licenses. So that may be one contributing factor. So we did a little bit more outreach.
Thanks, boss. My memory get a little bit faded here. All right, 97. This pretty much shows the percentage of licensed pets in Kansas City. This data came from AVMA Pet Ownership Calculator. Talks about in Kansas City, guess estimate 108,000. Excuse me. 134 dogs and 118,133 cats. So you wonder how we get the currently licensed percentage. This is what we do. We divide that for dogs, 19%, cats 3% to get 11% that we are currently. So that's how we get those numbers in terms of animals current licenses in Kansas City. Okay.
Okay, so the next strategy is about a plan to further improve animal response operations, and we've got a number of other topics that Patrick's going to speak to, but the first slide is actually a follow-up from our last meeting about, we talked a little bit about the animal shelter intake, in particularly coming from owner surrender and strays. And so KC Pet Project provided a little bit of follow-up data to answer that question of what the trend was. I think Teresa Johnson is here to speak to that.
I am. Thank you very much. So one thing I might mention before we get into this is one of the barriers to selling more licenses is the fact that not all residents have access to easily accessed and affordable veterinary care, veterinary facilities. And so a lot of our communities still have veterinary deserts. And so that is a big challenge for citizens that don't have the ability to put their dog on a bus or something like that. So clinics with SNKC, clinics that KC Pet Project does, more outreach in the community to help people be able to get a rabies vaccination so that they can purchase a license is going to be critical to be able to get that licensing number up. This slide talks about animal shelter intake, and so I understand there was a follow-up question from December on this. You can see owned dogs and cats surrendered for full year 2017 did go down a little bit. We did provide some outreach and some behavior work, behavior counseling, food, some resources to people who were considering surrendering their pets, and so we have seen that number decline a little bit, and it declined a little bit more for the first quarter of 2018. However, we did see stray dogs and cats coming into the facility from citizens rise significantly. And so for 2017, we saw that increase 17%. And in fact, for the first quarter of 2018, we've already seen a 58% increase in the number of stray animals coming in from the public. Overall, for the last 6 years, we've seen a 139% increase in owned animals being surrendered by the public and a 154% increase in stray animals being brought in by the public. And what we see is about 65% of those stray animals are being brought in by Kansas City, Missouri residents, but we also see 20% of animals being brought in by non-Kansas City, Missouri residents who say they are passing through Kansas City, find a stray animal, and bring it to us.
So they say.
Yes. Yes. Some of the reasons why we see owned pets surrendered, the top 3 reasons we see are behavior issues is what they cite. And some of those behavior issues, we find that we need more resources in the community to deal with providing help like classes, behavior classes, puppy training classes, outreach in neighborhoods to help people keep their pets and affordable veterinary care a lot of times too.
And the second being the health of the animal. A lot of people cannot afford veterinary care for their pets, and so unfortunately, they have no other alternative other than to just bring it to the shelter when maybe perhaps that's not really what their first choice is. And then moving and landlord issues. Although we don't have any breed-specific legislation in Kansas City, there are a lot of neighborhoods, a lot of rental properties and apartment complexes that still have a lot of breed restrictions. And so when residents are looking for affordable housing, many times they're unable to take their pets with them because of the breed they are. And so we still find a lot of people that have no other choice other than to bring their dog to the shelter when they have to move. Stray animals brought in by the public, most of them cite found running at large as the number one reason, but we also do have police drop-offs and then abandoned at the shelter. When we talk about owner reclaim rates for dogs, we saw in 2017 that for those that are brought in as stray animals, they're reclaimed by the public about 29% of the time. But of course, cats are only reclaimed about 3%. And if they are going to be reclaimed, we find that most animals are reclaimed within about 3.5 days. Otherwise, they don't wind up being reclaimed at all, and they're placed up for adoption. Any questions?
Good,
All right, thank you.
Thank you.
If I may say, thanks, Teresa. Getting back to the licensing issue, we do have a list of about 35 locations spread out through the city where people can get licenses. It doesn't have to be at your vet. You know, you could be at your pet shop, or it could be at, for example, NNI up north. You know, they don't have anything to do with animals, but they do sell pet licenses. So there are so many locations throughout the city. If you want to, you can obtain a pet license. But I just want to bring that up. Thanks again, Teresa.
One, before you move on, Patrick, Teresa, I did want to, I failed to congratulate you on receiving the Maddie Hero Award, and a great accomplishment. So congratulations on that.
Okay, we are, getting back to 98. Mayor, quite frankly on this, from my perspective, I think it boils down to staffing. You know, hiring and being able to keep staff plays a great deal in this regard. We have, the past 3 months, hired 5 officers, and as a matter of fact, 3 just started yesterday. So we are pretty excited about it and looking forward to training them and keeping them, you know.
What is your retention rate? I would imagine that retention is just as important, if not more so, than staffing.
You know, the last time we checked, the turnover was about 33%. Yeah, and it's been a challenge, and we continue to spin our wheels, continue to hire folks, and they move on to different pastures. You know, like everybody know, animal control is not the easiest. If you live in Kansas City, it's not it's not a joke. But we will continue to do what we can to succeed, and you know, it just issues like that, those things basically strengthen our resolve to see through it and make sure we do a good job for the city of Kansas City, Missouri.
Okay.
Okay, we slide 99. Oh, I'm sorry. 100. Satisfaction with animal control services. I'm looking at I know it's kind of awkward. I'm looking at the dissatisfaction rate. This is probably the lowest we've had in years, 15% dissatisfied. 48% in the gray area. If we can just move those down a little bit to the 37%, we'll be in pretty good shape. So that's one of the things we intend to do. Continue to do our outreach to everyone, and part of the education piece of it. You know, like I said, we have staff who, part of their performance standard is to attend one neighborhood association meeting per month to try to reach out. If any neighborhood association person is listening, they have animal control issues in their neighborhood, please call me. 513-1313, that's the Action Center number, but they can reach me. So, yeah, we'll do everything we can to improve our satisfaction scores. Okay. 101. The median response time for animal control calls. This is a new thing that since the audit, In the past, we used to track dispatch to arrival. Now we three different response time: creation to dispatch, dispatch to arrival, arrival to close. If you look at the creation to dispatch, it's pretty interesting. December and January, quite an anomaly. We're looking at 9 hours respectively, 9 hours and 6 hours. This is basically, calls go to PD dispatch. They have to hold on to those calls until they can find an animal control officer available to dispatch it to. I mean, December, I cracked my brain on this, looked at all the stats, and the only thing I can find in December was pretty much in November, we received about 209 complaints for cruelty. December, we had 304 complaints. January, we have 314 complaints, but still, in February, we got 230 complaints because we spent more time responding to cruelty complaints. So my assumption was, based on those higher numbers, make the creation to dispatch numbers pretty high, 9 hours. But still, one of the main factors that contributes to that is the overnight officer. Action Center is open from 7 to 7. Then after 7 p.m., those calls go through 911 direct to PD. So you have calls that are coming in late, and when we close for service, obviously there's no animal control officer to dispatch those calls to. We used to have overnight officer from 9:30 to 6:30 in the morning, but sadly he passed away back in September. So we have been short of staff. Like I said earlier, we just hired new staff. So once we get totally in good shape, we will assign one officer to another overnight shift. So that should alleviate these high numbers in terms of PD waiting for personnel to dispatch to. So once again, I also asked PD, I said, I'm waiting for a response from them. Is that something they can tell me that got December numbers to 9 hours from a jump of 1 hour in November to 9 hours and 6 hours respectively, December and January, So I haven't heard back from them. Hopefully they can look at that data as well. Hopefully it's not a mistake somewhere. Okay. Just can't wrap my head around this. Okay. 102. This is something that the brains of the city manager's office did for us. They cracked those numbers. Kate, are you willing to tackle this?
So this is actually also related to the audit in some ways. There's which Patrick will touch on, there's a recommendation that talks about analyzing the response time and the calls data to align with staffing, both staffing levels, but also staffing allocations, because animal control has been set up to be a 24-hour operation, although, as Patrick said, their overnight shift is currently vacant, so they're not running 24 hours. There's a variety of different shifts that overlap, and so there's some sense that there might be an opportunity to optimize response times by making some changes. So just as a first look at this, because it's kind of it'll be a pretty detailed analysis, I think. We looked at the overnight shift, 9:30 p.m. to 7 a.m., which is not staffed every day of the week, versus the midday, and I don't want to call it a shift because it's really many shifts that overlap there, but between 10:30 and 6, you have the maximum staffing for any given day, although it does differ quite a bit day by day, but that's where the most staff coincide. And so just looking at the calls breakdown just for March, only about 13% of the calls came in overnight. So probably justifying some presence then, but it's certainly not a major presence. Whereas that midday period did get about 51% of the calls. And if you look at the time frames, though, of create to dispatch, which is where you would probably expect to see the impact here, you do see a really big gap there. So looking across all calls, the create to dispatch for March was about 182 minutes, about 3 hours. But when you look at it in those two subgroups, for the overnight, it was about 6 hours, which, you think about something's coming in overnight and it can't be dispatched till an officer gets in, that makes sense, versus the midday was closer to 2 hours. So I think as we dig into this more, we'll probably find more. We'll certainly have more insights that hopefully can be looked at in terms of operationalizing.
Thank you, Kate. Okay, slide 103. this has to do with the recent audit. We, I think it was total of 17 recommendations. 12 of the recommendations have been implemented, complete. 5 of them still either going through implementation phase, and we anticipate complete implementation in the next 3, 4, 5 months. The first 5 that has not been implemented, facilitated a meeting between us and KCPAD project. That began in November, meetings ongoing. Shared vision for animal care control. We anticipate scheduling initial meeting in May with stakeholders. And we certainly believe a collective revision, of the ordinance with our stakeholders, shared vision could emerge from that. So that's one of the things we intend to do. Then standardized call types with KCPD for after-hour calls. Once again, city managers' staff, they are working alongside with us with PD to resolve that particular issue. Analyze calls to determine staff scheduling. Once again, working with city manager's office of performance management on analysis on that one. Ensure annual trainings required of animal control officers and supervisors. We just recently had 40-hour training at North Patrol with PD. It was the training was actually conducted by University of Missouri. We had 6 staff attended, 3 managers and 3 officers. We have also have a training scheduled for the new officers this month at the health department for the new officers coming in. We also have training tomorrow for bite stick training for some of the staff who have not had that training. I'm working with staff from the health department to go over again zoonotic diseases training for all staff. So it's going to be an ongoing stuff that we're doing in terms of training. Okay, new animal control facility. I may have somebody talk about this. I'm not too knowledgeable in this area.
We just thought that it was worth, since we were talking about the subject, putting in a rendering. This comes from our city architects, or via our city architect's office, and just shows a glimpse of what the facility might look like. And per the slide, excavation and construction planned for later this year. So
I want to know what's going on here myself too. So somebody talk about this?
I don't have any other updates. Troy, do you have any updates to add?
They're waiting to complete their private fundraising, so.
Thank you. I think the 105 strategy, responsible pet ownership through education and public service announcements. Like I said earlier, we have staff who are taxed as part of their performance standards to attend 1 neighborhood meetings per month. That's one of the education component of it. And we also have staff who go to all these fairs and you name it, post offices. We have tables set up and people come around. We educate them as much as we can. And we always get emails. It's the summertime now, so we start to get email from people who want us to be at their events. So we are open. Even at Earth Day celebration, we were there at the park, Swore Park, I believe it was 2 weeks ago or so. So every event that we are invited, we are there. We have supplies that we pass out, pooper scoopers, kiddie books that we pass out and to encourage kids to be show some interest in animal control issues. So that's all I have, Mayor.
Thank you. Sounds good. Anything? Anything from you? Nope. We're
Right on
good.
time.
Thank you all very much appreciated, and you're doing good jobs, and I like the coordination that you're talking about. That's sorely needed, so hopefully that'll bear increased numbers of fruit.
Yeah, that's right.
Increased amount.
Increased resiliency, yes. I agree with you.
Yeah, thank you. I'm always trying to get away with stuff. Thanks a lot, folks.